I'd like to introduce our next speaker, Teresa Chen from the Mass Eye and Ear Infirmary, who's going to speak to us today about OCT artifacts in glaucoma.
So I'd like to thank the AGIS for the opportunity to talk to you today. My topic is OCT artifacts in glaucoma. I have no relevant financial disclosures, although I'd like to say up front that all spectral domain OCT machines, whatever you have, all have artifacts. And I'm also not unfairly singling out OCT tests because we know that all glaucoma tests have problems. Disc photos can be blurry. The OATS study has shown us that 86% of visual field defects can't be repeated. And of course, the topic of this talk, OCT artifacts. So the overarching questions that we have for this talk is that OCT abnormality from real disease? Is it from glaucoma? Or is it from an artifact? Because if it's an artifact, we have to have the presence of mind to throw out that data point. So I'm going to go over some of the main artifacts that we see in the clinic. Although there are three main scans we obtain in the glaucoma clinic, the most common one is the RNFL thickness. So that's what I'm going to focus on for this part of the talk. Literature has shown us that up to 43% of RNFL thickness scans have at least one artifact. However, the good news is that over 80% of the time, these artifacts are obvious if we look carefully at the printout. So in Letterman style, I'm going to go over the top 10 artifacts in descending order. So first of all, number 10, cut-edge artifacts are uncommon, less than 1%. Of course, the edge of the scan is not even seen. Motion artifacts, the patient is moving so much, the scan is not completely in the display box. Of course, a good technician can see this right away and can redo the scan if this is seen. So again, the incidence of this artifact is relatively low. Incomplete scan, of course, the scan quality is so poor that the machine can't completely segment the entire 360 circle. PPA-associated errors, this is also rare, around 1%, and that's because Joel Schumann and other investigators before us have determined that with an optimal scan circle size of at least 3.4 millimeters diameter or more, that this actually circumvents most areas of peripapillary atrophy, but again, still seen in about 1% of cases. Missing parts, so vitreous floaters or debris can block parts of the scan so that there's no data, and of course we can't analyze the neurofibular thickness there. Cirrus can also have, of course, missing areas of the scan. This is a patient who is blinking and therefore there's no data here. And again, a good technician seeing this will hopefully redo the scan. So now number 5, more common artifacts is anterior misidentification of the RNL, such as traction or other things that are pulling on the nerve fiber layer. And so here you can see the computer is incorrectly segmenting the anterior RNFL too high, and this gives artifactually thick nerve fiber layer measurements that are in the supraphysiologic range of 400 or 500 microns. Here's another example of that. Here in 2015, the RNFL is properly segmented. However, in a subsequent year, you can see that the anterior RNFL is misidentified, and this is a segmentation artifact where the RNFL is artifactually thin. So here you can see this is not progression from glaucoma, but progression from an artifact. Number 4, poor signal is about 5% of scans. Here you can see on the spectralis scan the quality indices is 9. Now, why is this important? So if the signal is poor, Joel Schumann and other investigators have shown that dry eyes, for example, can cause poor signal, and this usually leads to thinner RNFL measurements. And of course, we all know lens opacities can also decrease signal strength. Now, when looking at these parameters, it's important to realize that parameters are different for different machines. So for example, in that example on the spectralis, 9 is poor, and this is on a scale up to 40. However, if you have a Cirrus machine, 9 is actually fantastic on a scale up to 10. And then again, for the ArtiView, 9 is very bad because this goes up to a score of 100. So different machines have different indices for quality. Number 3, posterior RNFL misidentification is more common than anterior RNFL misidentification. And the reason why, of course, is that with glaucoma, there is a decrease in RNFL reflectivity. This makes it harder for the machine to segment a poorly reflective RNFL from also the underlying poorly reflective plexiform layers. So here you can see an advanced glaucoma patient. The machine is telling us the posterior RNFL is actually down here when it's accidentally incorporating some of the plexiform layers. So here's another example of segmentation artifact. This one is easy to spot because you have an RNFL of 0 microns. We know this is an artifact and is not possible because of the floor effect. The floor effect is, of course, in advanced glaucoma patient when almost all the nerve tissue is gone. You still have at least 50 microns plus minus of non-neuronal tissues such as glial cells and blood vessels. And this floor effect is different for different machines, but is around 50 microns. So number 2, very common to see PVDs in our scans in about 14% of scans. And I call this the Goldilocks artifact because, as you know, Goldilocks had pores that was too hot, too cold, and then just right. So similarly, nerve fiber layer thickness measurements with a PVD can artifactually be too thick. It can be artifactually too thin, or sometimes it's just right, meaning the PVD does not affect the segmentation of the anterior or posterior RNFL, again, despite the presence of a PVD. So the number 1 artifact, which is not seen in all machines, but in the machines that need manual centration of the scan, you can have decentration artifacts, and it's very common. So why is this an issue? This is an issue because we know that the nerve fiber layer usually is thicker closer to the optic nerve and thinner further away from the optic nerve. This is in a normal anatomy. So here's a study by some of our local colleagues, and this is a normal patient with all green on the OCT scan. However, if you take the same patient and you purposely decenter the scan superiorly, you can get artifactual RNFL thinning superiorly. And again, this is just because we're scanning further away from the optic nerve head superiorly. Similarly, if you take the same normal patient and purposely decenter the scan inferiorly, you can get artifactual RNFL thinning here. And again, that's just because you're scanning further away from the optic nerve head. And of course, you can decenter the scan any way you want, nasally or temporally. So here's another scan where the scan is decentered temporally, which causes artifactual supratemporal thinning, but the technician simply recenter the scan and the patient is cured and now has a normal nerve fiber layer thickness. So very common. So top 10 reasons for OCT artifacts: decentration in certain machines, PVD in about 14%, poor signal about 5%, and the rest are closer to 1%. So not to isolate or just single out the nerve fiber layer thickness parameter, we all know that macular scans can have a high rate of artifacts, as well as optic nerve scans can also have a high rate of artifacts. So I'm going to go over 3 OCT diseases, and you can only have or be afflicted by these diseases if you have an OCT machine. So the first one is red disease. We all know this is a false positive. So the machine shows the doctor that this is red, the patient has glaucoma. But the doctor looks at the nerve and the field, which are normal, and knows this patient does not have glaucoma. So this is red disease. A common cause of red disease is myopia, because myopia can independently cause RNFL thinning. So again, the machine tells us that the patient has glaucoma, when in fact the patient is normal and simply myopic. So the cure for this disease, of course, is to throw out the OCT scan, and the patient is simply normal again with just myopia. Another case of red disease, high myopia, but normal fields, but again, red on the OCT. So yellow disease, I was reading about this in Steve Mansberger's paper in AJO this year. I don't know if he calls it yellow disease, but I call it yellow disease because he found out that when you see yellow on a scan, again, meaning that maybe the patient has glaucoma, he found that if you, 24% of the time, that these yellow scans became normal with manual correction of segmentation errors. So my interpretation of this study is that 24% incidence of yellow disease. And then the third disease, of course, is green disease. This is a false negative. The machine is telling you the patient is green and is normal without glaucoma. But the moral of the story is don't just look at the color scheme, because if you look at the entire printout, you can see the patient has glaucoma. So here's another example of green disease where the machine is telling us everything is green and the patient's normal. However, if you look here, you can see a focal defect as well as a supratemporal disc hemorrhage and an inferior central visual field loss. And again, this is green disease because the machine is telling us the patient's normal, but we know this patient has glaucoma. And like all diseases, green disease can progress. Here in 2013, you can see a patient with a 0.9 nerve advanced glaucoma, but some green areas. Then later on, again, this is green because you're accidentally incorporating the plexiform layers. But in a subsequent year, the same 0.9 optic nerve patient has all green areas and is supposedly normal, but again, still has a 0.9 nerve. So again, green disease is a false negative. So going over other artifacts that can be from different machines, this is a patient we had in clinic that we started out with a Stratus, had measurements around 104 microns for nerve fiber layer thickness. We upgraded to a Cirrus, so the patient had measurements that alarmingly went down. So this, of course, is worrisome for progression. But on a different day, the patient saw a different doctor who preferred the Spectralis machine, and the nerve fiber layer measurements went up again. So in looking at all the clinical data, this patient was actually stable and had artifactual thinning because a different machine was used. And this is consistent with literature, which shows us that the Cirrus tends to give lower RNFL measurements compared to Spectralis and ArtiView. And then lastly, it's important to keep in mind that different machines have different normative databases. None of them really have high myopes, and they all have different ethnicities. So in summary, it's important to know the top 10 artifacts we can encounter in the clinic. We need to be aware of specific OCT diseases. And then lastly, it's important to know the variations between the machines, which can also create artifacts. Thank you.
Very good. Excellent.